Glaucoma is a leading cause of blindness, globally affecting nearly 80 million people. This silent thief of sight involves optic nerve damage and visual field loss, secondary to retinal ganglion cell damage or cell death. The eye produces fluid from the ciliary processes to bathe the eye. The fluid drains via the trabecular meshwork, aqueous veins, uvoscleral pathway, and suprachoroidal space. In many adult patients over 50, the trabecular meshwork ages and the lens of the eye becomes larger, developing a cataract. This narrows the drainage angle, reducing the ability of aqueous to drain from the eye. Additionally, in some patients, the zonules that attach the lens to the iris rub against the posterior iris, releasing pigment that further blocks the outflow pathway. This alone, or in addition to other causes and genetic predisposition, leads to elevated intraocular pressure. This increased pressure goes on to damage the optic nerve, described as cupping. When this occurs, an intervention should be considered. Since as many as 50% of patients fail medical eye drop therapy, early cataract extraction can be performed to open the angle, and goniotomy can be performed to remove the damaged trabecular meshwork to help improve aqueous outflow. This can cure glaucoma in some patients with early disease. Patients with advanced glaucoma, due to decreased outflow, will need additional intervention. Dr. Daniel Laroche is a board-certified ophthalmologist and glaucoma specialist and president of Advanced Eye Care of New York. He is a graduate of New York University and Cornell University Medical College, Howard University Hospital, and New York Eye and Ear Infirmary for Glaucoma Fellowship, an inventor of the modified retrobulbar intraconal tube technique, a surgical treatment for patients with advanced glaucoma. This retrobulbar intraconal tube shunt procedure should only be used in patients with glaucoma who have had their cataracts removed. This procedure allows aqueous fluid to drain to the retrobulbar intraconal space, reducing the risk of corneal edema, which can occur when a tube is placed in the anterior chamber. Under local anesthesia, a supratemporal posterior conjunctival opening is made to place the modified tube in this quadrant in the retrobulbar intraconal space. A peripheral micro-opening is made to place a viscoelastic gel into the anterior chamber and to expand the space between the posterior iris and intraocular lens. This is where the anterior bevel-down cut silicone tube will be positioned. A small 23-gauge needle is used to make an incision, 1.5 to 2 millimeters from the limbus, into the ciliary sulcus. Then, the silicone microtube is placed. The position is confirmed with a second instrument. The tube is then tied to the eye with two interrupted 10-0 Prolene sutures. Then, a cornea scleral patch is cut and placed over the tube and either sutured or glued in position. The conjunctiva is then placed over the patch and tube, then sutured or glued into position. An inferior sclerotomy, or scleral window, is created with forceps, Westcott scissors, and a crescent blade. This will serve as a window for any potential choroidal effusions due to the lowering of intraocular pressure to the single-digit range. Cohesive viscoelastic gel is placed in the anterior chamber to keep the chamber formed for the first 72 hours. This connection allows the aqueous to drain to the retroorbital intraconal space. This bypasses the damaged trabecular meshwork to successfully lower intraocular pressure in patients with advanced glaucoma. Post-operative steroids and antibiotics should be given. Post-operative follow-up is required to monitor vision and intraocular pressure. This treatment allows many patients to achieve lower intraocular pressure using fewer medications. Risks and benefits are similar to traditional glaucoma tube shunts. This approach can avoid a bleb, reducing the incidence of double vision, as seen with larger, traditional glaucoma tube shunts. However, further research is required to compare this technique to the gold standard of trabeculectomy. Lifelong follow-up is required with your glaucoma specialist. Early low eye pressure may need to be managed with insertion of additional viscoelastic gel. Diet, exercise, and mindfulness are important aspects for glaucoma care as well. For additional surgical training for physicians and consultation for patients, Dr. Laroche can be reached by telephone at 718-217-0424 or 212-663-0473 and email info@advancedeyecareny.com. Family members of glaucoma patients can assess whether they are at higher risk or lower risk for glaucoma with the free desktop Laroche Glaucoma Calculator online. Thank you.